Okay, hello and welcome everybody to today's event at ODI on putting the politics into international public health. Thank you for coming, and I'd also like to welcome an online audience, I think of a couple of hundred people who are joining us today on the web. For those of us who are joining us online, there's an online chat room, and I'd encourage you to participate in that, pose questions, make comments if you wish to do so. Also, if anybody would like to tweet about the event on Twitter, please do so using the hashtag ODIHealth. I'm Tim Kelsall. I'm a research fellow in politics and governance. I'm chairing today's event. I have a few housekeeping points. First of all, this event is on the record, so if you have anything nasty to say about anybody, make sure that you can back it up. If the fire alarm sounds, everyone should make their way through these doors and out by the reception. Please turn off your mobile phones or put them on silent. And I'd also like to let you know that there are publications relating to today's event, including by Olivia, who's just wandering off.
I'm just closing the door.
Okay. Called What Does Adaptive Programming Mean in the Health Sector? And those are available outside. So the title of today's event is Putting the Politics into International Public Health. Well, what do we mean by this? Well, a popular definition of politics is who gets what, when, and how. Another is that politics is about power, or the ability to achieve desired results. Another is that politics is about processes of agreement, disagreement, conflict, consensus, and struggle. And I think that many people who work in the health sector will realize that although technical issues are very important to health outcomes, health isn't purely a technical matter. That's because when it comes to issues as diverse as policy choice, resource allocation, personnel management, and patients' rights, we can expect to find politics. And I think another area where we can expect to find politics is around issues of quality and quality improvement. Because to improve quality, you have to change the way people do things. And as people are often reluctant to change, you need to find a way of persuading or forcing them to believe that change is desirable or necessary or inevitable. And doing that may involve engaging with a whole structure of authority relations, from the grassroots to the national level. So politics is pervasive in issues of quality improvement. And to discuss that today, I'm delighted to welcome our speakers. Olivia Tulloch, Lillian Otiso, who's joining us on the phone from Kenya, Miriam Techtmeyer, and Vicky Doyle. So Olivia joined ODI last year as a research fellow in the Politics and Governance program, and she works specifically on the health sector. She has a research interest in strengthening health systems, and in particular, the delivery of community-based health services. Today, she's going to be providing introductions to the concepts of adaptive development and quality improvement, and providing insights into the challenges of the health sector to work politically. Lillian, on the phone, is a medical doctor, and she is the Director of Programs at LVCT Health, which is a Kenyan NGO, where she's led the design and delivery of comprehensive HIV programs at community and facility level, which have reached over 1.3 million people. And today Lillian's going to present a case study from Kenya talking about the challenges of quality improvement in a decentralizing health sector. Miriam, to my left, is a senior lecturer at the Liverpool School of Tropical Medicine. She's a consultant physician in infectious diseases and conducts implementation research in quality improvement for community health in the UK, Africa, and Asia. She's the principal investigator and overall coordinator of a large EC-funded multi-country study on close-to-community providers of healthcare called Reachout, and she's going to tell us more about Reachout and its health system's approach to quality improvement. And Vicky, on my right, is a UK-based health development professional and Director of Capacity Development International. She's got more than 20 years of experience working in research, education, management and consultancy, and extensive experience in the development of context-specific healthcare quality assurance systems. And today, Vicky is going to present the findings from a recent consortium workshop in which all 6 Reachout countries analysed the challenges of embedding quality into community health programs. So we're going to start with Olivia, and you have about 9 minutes.
Is this okay? Thank you very much, Tim. So I'm tasked with introducing and explaining the concepts which underpin our discussions today, and also sowing some of the seeds for the debate. Our audience here and online is intentionally quite a mixed bag of people from international development, from public health, from political economy, and probably more beyond. But as a panel, we are public health professionals. So during the debate, we'll be excited to be getting insights from beyond health to see what we can learn from you. Forgive me for keeping my contribution quite a simplistic one, but given the mix in the audience and the tendency for researchers in health and international development to be rather jargonful, let's try and make sure that we cut the jargon today. As Tim mentioned, the framing of today's events is the paper on adaptive development in the health sector, and you can pick that up outside, but I will be talking about the key concepts in that. And you can refer to it afterwards, of course. So, for many of you working in international development, the ideas of doing development differently or adaptive programming will be familiar. But in my experience, a lot of these concepts haven't really trickled down to the public health sector. The principles are not particularly new, and I'd like to argue that in the health sector, we are actually already doing adaptive development quite often, though perhaps we don't know it, and perhaps not fully. So what is it? You can say it's a set of principles. And if we are to do adaptive programming, one of the first principles that we would follow is to avoid designing our programs using what we call development blueprints or best practice models. And the reason for that is that if we are being adaptive, we shouldn't have decided in advance what our solution is. Rather, adaptive programming is something that's problem-driven. And importantly, initiatives should learn from our experiences as programmers and as practitioners. So we should take iterative approaches, taking small steps, making small bets on ideas and interventions which may or may not work. This can be done through a cyclical process. So at the start of that process would be the problem identification, followed by planning. So planning the initiative to address that problem, then doing that initiative, reflecting on its success or failure, and then revising it if necessary. So that would mean that bad ideas are dropped and good ideas are pursued. That's adaptation. The next principle would be to work in a way that is locally led. locally owned. That's so that stakeholders drive change, mobilise change, and not donors. And I think we'll come to define what those stakeholders are as the session goes on. In the health sector, we really think that we are already doing locally led research, but I wonder how much we really are. We should be looking at problems that are locally identified down to grassroots levels and that continue to be refined by local people throughout the process. So it's an approach that builds trust. Finally, though, adaptive programming is what we call politically savvy. And that means working to understand how political structures, power relations, and motivations of different stakeholders in a system, any system, work. And using this knowledge to think about the options for what we might do differently in our programming, given what we know about those political economy issues. So that brings me on to what we mean by quality improvement. So when I started at ODI last year, one of the first things I had to consider was what can a governance and politics programme make use of in a person with a public health background, and where would I start? And as soon as I came across the idea of adaptive programming, which is a core part of our work in the programme, I had a kind of epiphany of like, this is a lot like quality improvement as we know it in the health sector. And there was somewhere to start from. So quality improvement's a methodology, and it's also based on principles. And that principle is that there's an opportunity for improvement in any process. It can be applied to almost anything. It's meant to have started in the manufacturing industry in the last century, but actually, if you look back to Florence Nightingale, I think we can say that she was doing quality improvement in nursing during the Crimean War. So quality improvement is part of a broader process, and you can see that in the left-hand diagram of what the health sector calls quality assurance. And within that diagram, you can see there is a little part which is to improve. Quality improvement itself is a cycle. You'll see the other set of cycles to the right-hand side of the slide. And it's a change cycle. So we use it to identify parts within the health sector that don't work well or where there is a performance gap. That might be waiting times in the UK NHS, or it might be poor motivation of community health workers in Mozambique. But if you look at the area of poor performance, then we try to improve it. And when you look at this idea as a cycle, you can see there PDSA, that is the plan, do, study, act cycle. So this would mean, in reality, having a team of local staff to attempt to understand the causes of a problem, and then planning interventions to make improvements, to test the interventions, study them, and then adapt those which are not successful. And at this point, it should start to sound quite familiar, because isn't this quite a lot like how I described what adaptive programming is? So in quality improvement, we are learning by success or by failure, and we use cycles to do short-term trials of interventions and to create improvements. And as our cycles are repeated and adapted, the idea is that incremental change will occur over time. So given these very brief overviews of those two concepts of adaptive programming and quality improvement, can we say that quality improvement is really a sort of adaptive programming? Case studies would suggest, yes, it is, but only to some extent. And I've tried to illustrate that in this table. Because actually, adaptive programming asks for a little bit more than we ask for in quality improvement. And maybe some of these principles are actually quite hard for the health sector to grasp. So in the top two rows here, we'll see a good fit between the two ideas. But then when we look to how much quality improvement is locally led or politically savvy, we'll see that actually some divergence occurs. Quality interventions themselves are often locally led, but much quality improvement occurs through donor-funded projects and may follow a donor agenda. There'll be more about this to come. But also, the other important issue is whether or not quality improvement is politically informed. You could argue that quality improvement in the health sector is entirely apolitical, and that it actually should be apolitical. In public health, we tend to shy away from engaging politically and are often poorly equipped to do that political work. So there may be some strong arguments for this and against it, as we will hear in the next presentation, which is about decentralisation. And that's it.
Thank you very much, Olivia, and thank you for keeping to time. Now, I want to ask, is Lillian on the phone there? Lillian, can you hear us?
Yes, I can hear you.
Great. And are you ready to speak?
Yes, I am.
Great. Please go ahead.
All right. Thank you, Tim, and thank you, Olivia, for making that introductory section. I will speak about our experience as LVCT Health in implementing quality improvement projects in the context of devolution. And just to begin, I'll start by speaking about LVCT Health, which is the organization I work for. We're an indigenous NGO in Kenya that has used research and programs to influence policy since establishment. We were actually set up in 1998 as a research project and registered as an NGO in 2001. And since then, we've been using research to inform national policy and guidelines and practice to enable projects to scale up. And those images you can see on your right are some of the latest policy guidelines that we've provided technical support to develop in country. And we use a quality improvement approach and believe that we provide technical support to government to use the same approach to continuously improve the different projects. And our knowledge of the political processes, power, and how to work with the different government structures has enabled us to get a lot of government buy-in and support and achieve those results. And specifically, we are currently using a quality improvement approach to strengthen community health systems in 2 counties in Kenya. And in my next slides, I'll be talking more about that context. So in the next slide, I just want to give a background of Kenya, where we have a new constitution that was promulgated in 2010. And it brought about a lot of unprecedented changes in the political landscape and captured a lot on the health sector. It resulted in decentralization of health services from the national to county level, from a place where we had one national system with 8 provinces to now having 47 new counties that were established, and each being an authority on its own. And of significance is that the health sector did not play a significant role in the process, as it was assumed to be a very political process, and they were therefore caught unawares by what devolution meant, where the service delivery in healthcare was decentralized from national, such that power moved almost completely away from the national level to the county level. In the next slide, I'm talking about how there's a County Governments Act that actually defines the increased power to the counties, and that meant transfer of health workers and finances and the determination of health priorities and budgets to the county level, which was a major shock to the health sector. Only the policy setting, standards, and training were left at national level. So all healthcare workers had to be employed within counties, and it resulted in major shakeups and delays in doing a lot of our different projects. There was an instability with health workers' strikes and just a lot of discontent, and we're still in the process of settling down because it's a process that occurred very quickly, and we're still in that transition mode. On the next slide, I'm trying to explain how the devolution works itself and how it created a parallel system of government. With devolution, we had the 2 systems of government. Before that, what you can see on your left was what was the structure or the political system, where we had a president with a minister and permanent secretary and department heads, followed by provincial heads. And the power rested within that line, and it was very easy to implement projects as long as you had approval from the national level. And in most cases, health managers did not have to deal with any politicians or political offices, which is what the senior offices are perceived to be. But from the changes that happened now, the system on the right emerged, and now we have the county level led by a governor, and who sets up an almost similar system with a county executive who is like the minister, a chief officer, and the director of health, who are all powerful political offices and not necessarily health medical workers. So this system has, there's also the Council of Governors that is shown there at the center, and that is the communication point between national and county, in that there was now a break. There's no direct communication, and the national system has no mandate over the county system. So how does that actually affect implementation of projects, and how it influences our projects? As an NGO, the entry process used to be approval at the national level and direct access to the province and district. But with devolution, now you must seek approval at the national level, usually higher than what we were used to before, so it's very political. And then the department head of that unit that you want to work with, but then followed by the approval at the county level, which is a whole new process. And with the changes, the county can approve or reject your request or alter it if they decide to use a different approach. And this happened to us in our Reachout project, which is going to be spoken of, but it's really about strengthening community health systems. And we went in knowing that the approach that they're using is one way, and it is what was being used at the national level. But we found on the ground that the county had decided to change their approach of how they're doing things, and we had to quickly adapt and change to suit that local context. It resulted in a lot of delays, but we were able to adapt to those shocks because as an NGO we are a bit faster in changing, but that's not necessarily the same at the facility level. In the next slide, it's just speaking about the lessons that we learned from a quality improvement perspective and the challenges we saw. The key lesson is that you must be very adaptable and know politics well enough to implement a project in government, especially during a transition period like this one. There's a lot of bureaucracy that was created. There were multiple levels that came up that we had not anticipated before. And the creation of offices, of political offices within the county level that we as health workers had not really had to deal with was something new, and it forced us to be quick and adaptable in terms of how do you implement a project. If you wanted to do it this way and they change, what do you do differently? There's also a lot of lack of clarity of certain roles or PowerPoints and new offices that came up, and varied standards across the different counties. So in this case, especially when you think from a quality improvement approach, you started from thinking that this is the problem. We already had identified problems, but these were before devolution. But after devolution, the problems were new. So identifying problems was a new process, and with a new context about what people want and what do those local leaders actually want to achieve. So having to think about that was required a continuous process of adaptability. So in the next slide, it's really a reflection, and based on our learnings, is the health sector ready to deal with political changes? And with politics comes issues of power, decision-making, and what is the political landscape, what is in the interest of the politician or the leaders or the different leaders on the ground. So health workers have to know who has the power, who is a champion, who is a decision-maker, to allow a project to succeed. And in our Reachout project, where we were trying to implement the quality improvement, we have been able to make some progress because of understanding the power brokers and being quick and adaptable to the changes in the county and the sub-county level, as well as the national level as they take place, because we've kept our ear on the ground, recognizing who makes the decisions, and it varies across the different counties. And it's our belief that health managers and implementers need capacity building on advocacy and dealing with policy to achieve program improvement and outcomes in the health sector. In the next slide, I just want to talk about, or to conclude by talking about how it's important that as health workers, how do we get health or a quality improvement project embedded? We have to understand the approval process and what goes into all these things. In the new structure, the health managers get input from the project programs and come up with plans and budgets. And this is what is shown on green on the slides. So they get input from the community itself, the staff, and the county health committee is able to come up with their plans and priorities. And that forms the problem identification stage. But then these must be presented to the political offices of the County Executive Committee and the county assemblies, who are actually elected members, what is shown in blue. And they are the ones who decide what is approved and what is budgeted for or not. And for it to be accepted and funded, you have to ensure that they understand the priorities or the needs of these local politicians to be able to move forward. So many times projects have failed at this stage and they have to start afresh again with a problem identification which is aligned to the political needs and making it move forward. So, but by understanding these politics, LVCT Health has managed to enable Reachout projects to move forward by being able to align with the needs of the local leaders. And we hope this approach will enable us to get our QI approach in community health systems embedded and sustained beyond the life of the project. So in a nutshell, that has been our experience, and we'll talk more as the day goes on. Thank you.
Great, thank you very much. Thank you very much indeed, Lillian. Now I'm going to hand over to Miriam, who's going to talk about her experience of the Reachout programme.
Thank you very much for inviting me to ODI and for coming to listen in person and virtually to hear a little bit more about Reachout. Reachout is a EC-funded project that runs over 5 years and it works in 6 countries. Our aim is to maximise the equity, effectiveness and efficiency of community health worker services in rural areas and urban slums in 6 countries, 4 in Africa and 2 in Asia. And I would call those 3 E's, equity, effectiveness and efficiency, the dimensions of quality that we're particularly interested in. We focus on community health workers or close to community providers because they are seen as a possible solution to universal health coverage and achieving sustainable development goals. There's a lot of pressure to increase coverage to get health services out there, and a lot rests on them. Because in fact, they're the least supported of cadres, the least educated, the least trained. Some of them may have a few days training, maximum about 1 year. They're mostly school leavers. Some read and write, some don't. Some are salaried, some are volunteers. They have very varied tasks. And in fact, every vertical programme in the world appears to want to use them to do everything. Collect sputum for us, distribute bed nets, do HIV testing, do maternal health, weigh babies. And as we push to increase coverage and universal health coverage, are we undermining quality? And is that, in fact, doing communities a disservice? So we focus on that cadre for that reason. And there's a nice quote down there about how we can't expand access without quality. And Reachout is a platform. You get a lot of studies that are about, we use community health workers to do this, to provide antiretroviral therapy, follow-up adherence counselling. And it worked really well. It can be task shifted. Success, quality is improved. Paper is written, tick. Promotion achieved, yeah? You get a lot of that, but Reachout enables us to look at that over different countries, different types of community health workers, beyond a disease-specific focus. And it gives us time as well to follow up what happens over years and not just what happens in one short project. Because it's not that hard to do quality improvement. It is hard to embed change and to really understand whether it's right to use this cadre. And why Reachout is a great platform is that it can use innovative methods, in particular listening to community voices, because community health workers are this amazing interface between the community and the health system. They come from that community, they speak that language, they understand both sides, and that is a very unique opportunity to understand real local health needs. And when I talk about local ownership, I often think about it as community ownership. and not government or ministry or that kind of thing. So down the middle of this slide, you'll see a kind of timeline. Reachout is a 5-year program. We are about 3 years through this month, and we've completed a multi-method, multi-level context analysis in each country over the first year. And that used research to identify problems. And they were discussed with stakeholders, prioritised, and quality improvement projects have been going on in each of these contexts around certain key areas. And we're now reaching that bottom circle where we're shifting from a researcher-led quality improvement project to seeing how quality embeds in community health. So developing interventions, but seeing what happens to them next. The areas that we chose to improve on were the ones that came out most strongly in our inter-country analysis. What was amazing about our context analysis is that if you took away the countries from the quotes and from the data, you wouldn't know that it was informal providers in Bangladesh or it was paid community health extension workers in Ethiopia, because the quotes were so similar. It was incredible, particularly around these areas of supervision, engagement with community, around referrals and referral systems, and about coordination between vertical programs. And our literature review came up with this complex kind of framework of multiple factors affecting performance, and all of those that had come out of our country work were reflected there, but had come out much more strongly when it came to drilling down to the context. You should be familiar with this cycle. And essentially what Reachout had been working on, like many other research-driven projects, was improvements, individual improvements. And like I've said, it's great, a great opportunity for analysis within and between, but are those approaches, those improvements, sustainable on their own? And the challenge now is moving from a research-led to a district-led system to assure quality in community health. And that requires quite a culture shift in thinking in both our national programs and in vertical programs, but also in donors and donor thinking. And that's why this particular session is such a good opportunity for us to think more broadly about those shifts and how we embed the whole cycle of quality improvement and what that means, and a little more on what local ownership means against each stages of that cycle. What does local ownership mean in planning? How do we define equity in planning, for example? What about the standards? How nobody's defined what we're embedding, what quality means in community health programs, for example. How do we keep it simple, small and iterative, doable, if it's to be locally owned? We need to monitor some data, but how do we get those locally owned? How is data shifted from being something that's transferred up, you never get any feedback on it, to something that you use? And our experience is that there's millions of guidelines and registers, and they have to fill forms, but none of it is used. In fact, it's just an impediment to quality. And what about the capacity for looking at data and then identifying a problem and analysing that problem and coming up with solutions? That's not just an intuitive thing that you just do and say, oh, local ownership, there you are. Now we can identify our own problems and crack on with it. So our additional research questions now are much more about what has worked and how can that be sustained? What do we mean when we say sustaining? And how do we measure whether a culture of quality assurance is embedded at these different levels and is locally owned? What are methods for that? What are indicators for that? We often don't bother beyond the end of so-called project lives to measure these concepts around local ownership and embedment. And I keep coming back to, if it's not happening at the community, then it isn't happening. So there's a lot of stuff we can sit here and do. There's a lot of stuff even Lillian can sit in Nairobi and do. But if it's not happening in the communities, is it really happening? So we really need to hear the voices of communities. And this is a photo, thanks to Robinson Karuga in Nairobi, of a community dialogue day where you can see a chalkboard or a flip chart paper, but they're still called chalkboards, I think. Lillian, correct me if I'm wrong. And a discussion around data and what's happening with the community health programme. So Reachout is a platform for testing and also embedding initiatives and understanding the potential of community health workers. It's also shifting from project-led to district-led approaches, and that raises a lot of questions for us, and it would be great to hear more of your insights on that. And it makes us think about what we mean by ownership at each stage of that quality assurance cycle and what local means. Please do come and find out more. Come and see me or anybody else at the end. Visit our website, tweet, follow us on Twitter, read some of our papers and outputs from the last few years. And above all, if you're interested in the whole discussion around community health workers and universal health coverage, join the thematic working group in Health Systems Global. It's just an email, and that puts you in touch with the whole community of practice around community health workers. And if you email Faye, she'll link you up with the thematic working group.
Okay, thank you very much, Miriam. And now we move on to Vicky, who's going to give us some more insights from the Reachout programme.
Thank you. Okay, thank you very much. As Tim already mentioned, I'm going to be talking about some of the ideas and findings that were presented at a recent consortium meeting in which the 6 Reachout countries analysed the challenges of embedding quality into community health programmes. And I think what we were really interested in is really trying to probe, well, what is the actual reality? When we talk about embedding quality, what does that really mean for the community health worker working in a rural district, in a rural community? What does that mean to people at the district level? And what does that mean at national level? I think it's very common to see successful improvement projects which have been externally funded and externally driven. Lots of nice pilots, lots of nice results. But again, it's all too familiar. When the funding stops, the project stops, and a lot of that energy goes. And so really what is required is a far more pragmatic approach to strengthening local ownership and leadership of those projects. So even when you may be working on problems which have been identified by the community as being problems, still the projects may be still externally driven. And so when we talk about a pragmatic approach, we're really talking about looking at best fit rather than best practice, because I think all too often we don't have those robust institutions there to support a lot of what ideally could work. So it's really looking at what is feasible within both the political and institutional context. So I suppose the question is, how do we embed quality into the national and local health system? And I just think in the 20 plus years that I've been working in international health, quality of healthcare has received increasing political and public health attention. And that has been partly fueled by donors and external programmes, but also, I think, as Lillian was talking about, due to growing local autonomy, devolution and decentralisation of health systems. But what I have observed in the last 20 years is we still are seeing very fragmented approaches to improving quality. Examples of great national guidelines, even here, implementation guidelines for the Kenya Quality Model, 2011. But often these very well-written guidelines and strategies never make it past the national level. They remain paper documents. We also see very excellent isolated projects, but limited scale-up when funding ceases. So what are we talking about when we're talking about embedding quality? This is a definition which came from the Healthcare Improvement Project, which was a research and evaluation report from 17 countries doing quality improvement, and they describe embedding quality as establishing and maintaining continuous improvement activities as an integral, sustainable part of a health system or organisation's daily activities. So it's when it becomes part of everyone's job. But I think we have to be very careful that this is not at the cost of losing innovation, creativity and flexibility. So I was asked to come out to help facilitate a meeting for Reachout in looking at how we can move forward from this project or researcher-led quality improvement to really getting it far more locally led. And what we did here was we had a multi-country stakeholder workshop which really looked at how we're currently doing quality improvement, what is it that we're trying to embed, what is the actual reality on the ground, and where are those capacity gaps. And so we went through what I would call an iterative analysis, looking at strengths, weaknesses, opportunities and threats for embedding quality improvement. And really the purpose of this was to get the different stakeholders who were present, that included researchers, policymakers and implementers, to really look at both not only their own internal world they're functioning, but the external operating environment in which quality improvement is taking place. Really pushing people to think beyond health and to also to share experiences and learning with one another from the different Reachout countries, because they all have different political and institutional contexts. So I think, and really to look at how can we use this analysis to start bridging the gap between ambition, need and capacity. And so this was a very iterative process throughout the week, lots of post-it notes and things being moved around. And this actually, we also had policymakers there, both from national and sub-national level, as well as implementers, where they were also, we heard their voice of some of the challenges of trying to embed and align projects with national strategies and district strategies. So their voice was also fed into that process. So by the end of it, each country had developed their own SWOT, looking at the internal and external factors, both favourable and unfavourable, for embedding quality improvement. But we had quite a lot of generic themes came out. And I think some of the strengths were very much around technical skills in quality improvement, where we had researchers working alongside the districts, the sub-districts, and trying to develop robust quality improvement tools for different aspects of community health. But also what was highlighted was actually the weakness within the health system in actually being able to analyse and use data at the district and sub-district level, which is going to make it very difficult to embed quality. Advocacy capacity was again seen as something very weak. An overload of guidelines, tools and standards, and often conflicts between different programmes as to which standards were the right ones. In terms of opportunities and threats, I think one of the key things which came out, which already Miriam has alluded to, was that there is very much a renewed interest at national level in community health workers, because it's seen as a potential solution to universal health coverage. But the threat of that is the ever-expanding service package that community health workers are going to be expected to deliver. So this is the reality, the context within which you're trying to embed a quality improvement programme. So in terms of reflecting on the SWOT analysis as a useful method, it was something which was fairly simple to do. People understood the tool. It did bring a wider lens for people looking at the programme to go beyond just their own internal environment, but to be looking more externally. I think the iterative process and where people could be learning from one another and looking at where those commonalities were, so that they could also start looking at, well, what are the kind of strategies we can employ to overcome this, were really useful. But I think some of the key capacity gaps which were coming out were an ability to work politically, advocacy and communication skills, as well as technical skills around quality improvement. And as I said, we often see quality improvement programs working very well over a short period of time because they only focus on the technical skills, but those broader skills are also required. And I think the biggest challenge now really for the programme is turning that analysis into action, because we're talking about developing capacity in multiple skill areas and at multiple levels. So really, just a few questions which have arise from this analysis is we know that often short-term improvement projects disintegrate. Is it because those who are leading or implementing these projects are not politically savvy? So I suppose, how can politics and health work better together? And what does this mean practically? What does that mean for the community health worker, someone working at the county or district level? And then I think in terms of embedding quality, I think at the end of the day, what health professionals really care about is being able to work in an enabling environment that allows them to provide the best care possible, which means an environment that values and empowers its workforce to innovate and improve. It's not about confining people to doing box-ticking exercises. So embedding quality, what are the practical implications for frontline community health workers, the county level or district health management teams and policymakers? What are their roles and responsibilities? And who needs to be politically skilled? I'm very much hoping that you can answer some of those questions to help Reachout move forward. Thank you.
Great. Thank you very much, Vicky. Thank you to all the speakers. Some very interesting papers there. And one of the things I like about them is that although the speakers are not themselves political scientists, they all demonstrate an awareness of the importance of politics to health. So, for instance, just picking a few things from the presentations, Olivia asks, is quality improvement politically savvy enough? Lillian says that if you want to make projects work, you need to know who the local power brokers are. And Miriam asks, what does local ownership mean in different country contexts? And Vicky is searching for pragmatic and politically feasible approaches to embedding quality. So with those points in mind, what I'd like to do now is to open it up to the floor and take some questions for our speakers. When you do ask a question, please could you state your name and your organizational affiliation. And please try to speak clearly. There is a mic if people feel that they need that in order to project. Sorry. Yes, so especially so that the online audience can hear, it's useful if people use the mic, actually. Okay, so I'll take questions in groups of 3, and then we'll hear back from our speakers.